Hello, everybody. Thank you for joining us today. It's my great pleasure to introduce Dr. Mina, a highly experienced professional. Please give me a warm welcome.
Thank you. Thank you, James. Thank you so much, ladies and gentlemen, for being here with us today. I'm Dr. Mina Mohab, endodontist from Egypt, and today I'm going to share my clinical experience with you about bioceramics in daily practice. We are going to talk about root ST and BT, different clinical applications. root ST is a pre-mixed bioceramic sealer that comes in a syringe form, while root BT is a pre-mixed bioceramic putty that comes in a capsule form. Composition, both are composed of calcium aluminosilicate compound as a bioactive component and zirconium oxide as a radiopacifier, which does not cause any discoloration, and a thickening agent. Of course, the uses of the bioceramic sealer as a permanent root canal filling material in conjunction with gutta percha, while the uses of the putty is in vital bulb therapy, either in direct or indirect pulp capping, partial or complete pulpotomy, regeneration, revascularization as a retrofilling material in apical surgery, lateral and furcal perforation repair, internal and external root resorption, and as a retrofilling material in apical surgery, and the epixification procedure as a putty plug. Nowadays, there are so many studies that support the use of bioceramics. If anyone is interested to search for the titles. And here is a recent study that was published in July 2023, a critical review of the material properties guiding the clinician's choice of root canal sealer. In this study, they compared the different PC sealers worldwide, and they classified the hydraulic cements as follow. Low charges lower than 20% calcium silicate content, medium charges higher than 20 and lower than 40%, higher charges equal or higher than 40% of calcium silicate content. When you purchase any bioceramic sealer, you should search for such percentages. While the percentage is high, you can purchase the BC sealer. According to VERICOM's material safety data sheet, root ST contains 50 to 60% of calcium silicate content, which is considered one of the highest PC sealer worldwide. What is hydraulics? This is our basic technique. This is our main technique in obturation. Simply, hydraulics is the injection of the bioceramic sealer into the root canal system, then applying your master cone gutta percha to the full working length, which act as a piston that push the sealer into any susceptible microanatomy that may exist. Is it powerful enough to fill the whole root canal system to get a 3D obturation? Let's find out. Here is a quick video that shows the sealer flowability and consistency while injected in a plastic block where 3 lateral canals were simulated. Look, when we inject the sealer only, before adding any gutta percha cones, the sealer flows through the very long lateral canal easily. Here also, when you inject the sealer flows through the lateral canal. It's very easy. After that, you will put your master cone to the full working length, sear off the gutta percha, and you're done. It won't take from you more than 5 seconds. Here are the examples. Here is a lateral canal filled related to upper lateral incisor, lateral canal filled related to upper canine. 2 lateral exits are filled related to lower first premolar, filled with the sealer, same technique. Here are 2 lateral canals filled related to upper second premolar, an isthmus area filled related to upper first premolar, just filled with the sealer. Here is a lateral canal filled related to the mesial root and apical delta filled related to the distal root of lower second molar. Here is a lateral canal filled related to the mesial root of lower first molar, and here is the 3-year recall. The lateral canal is still filled with the sealer, which is very important for the bioceramic sealer to last, and you see it periodically in the X-ray and the follow-up X-ray. Here is a lateral canal filled and an isthmus area filled related to the mesial root of lower first molar, and here is a 5 months recall, shows healing and the lateral canal is still filled with the sealer. The sealer did not washed out, did not resorb by time. Here are 3 lateral canals are filled related to the distal root of lower first molar. Here is the lateral canal filled related to the palatal root of upper first molar with 4 roots. Okay, this is a different scenario. This is a type C lower second molar. I wasn't able to achieve patency, so I injected the sealer and added tapered auxiliaries. I added tapered auxiliaries. Look at this X-ray. Here is the tapered auxiliaries. The sealer, no any lateral exits were filled. After I seared off the cataperca, I got 2 lateral exits filled with the sealer. And here is a 3 months recall after indirect composite restoration. The lateral canals are still filled with the sealer. In this case also, I wasn't able to achieve patency. So after I injected the sealer, I got a tortuous lateral exit filled with the sealer that was nearly impossible to be negotiated with hand files. No file can enter through this area. Again, the distal root of the lower first molar, I wasn't able also to achieve patency. So after I injected the sealer, I got an abrupt 90-degree lateral exit filled with the sealer. I couldn't also scout or manage to enter this area with the hand files. Here's the lateral canal filled related to the palatal root and 2 lateral exits related to the mesiobuccal and distobuccal roots. Third lateral exit in the distal root. Here's a loop filled in the mesiobuccal root of upper first molar, a loop which is an accessory canal that divides from the main canal and return back again to the main, which is called loop. This is called loop. Upper central incisors has more than 40% incidence of accessory canals. And this is different microanatomy related to upper central incisors. Well, root ST will help you achieve the optimum apical seal on almost all types of cases, especially in the following case scenario. Long roots more than 25 millimeter. In case of extremely curved roots, multi-planar curvature, it's S-shaped curvature. In case of conservative shaping, teeth with external root resorption, compromised roots for strengthening, large periapical lesions as it promotes healing. It's an orthopedic bone cement, so it promotes healing. And in cases of limited accessibility and limited mouth opening, this is in case of multi-planar curvature combined by conservative shaping related to upper first molar. Multi-planar curvature combined by conservative shaping related to lower second molar. Here is also multi-planar curvature combined by conservative shaping related to the mesial root of lower second molar. In cases of long roots, how you will obturate such long roots? This canine was 32 millimeter length. You have to inject the sealer, put your getapercha cone, and you're done. You can't do anything more than this. Here also in cases of long and curved roots, separated file retrieval. When we retrieve a separated file, we lose some dentin. We compensate the lost dentin using bioceramics as it bonds to dentin and act as a monoblock. Both are becoming one, so it strengthens weak roots or undermined roots during retrieval. Here, after we retrieve the separated file in the lower second molar, we compensated the lost dentin using bioceramics, and here is a radiolucency. The 1-year recall shows complete healing. Here also, after we retrieved the separated file, we compensated the lost dentin using bioceramics, and here is the sealer flows through a furcal canal related to the furcal radiolucency. And here is the 1 month recall after crown placement. This case has a different scenario. After I retrieved the separated file, the canals were oozing exudate, and I had to finish in 1 visit. So I injected the sealer and finished the case. Look at the size of the radiolucency, it's very huge. Here is the 8 months recall, shows complete healing, and the sealer is still the same, did not washed out, did not resorb. Actually, it's a very, very tough test for any bioceramic sealer to withstand such tough circumstances. The sealer can be easily washed out by the exudate before its final setting, as it takes about 2.5 hours for the sealer to set. But thanks to the quality, consistency, and the high percentage of the calcium silicate in the composition that allows the sealer to set without being washed out. In this case also, after we retrieve the separated file, we compensated the lost dentin using bioceramics. This is a treatment case that went from simple to very difficult. Unfortunately, during the tubercle removal, I separated 4 instruments in the mesiolingual canal, and 1 instrument goes beyond the distal apical foramen. I managed to retrieve all 5 instruments. Of course, we compensated the lost dentin using bioceramics, and here is a quick video that shows the procedure and the retrieval of all 5 instruments. This is instrument number 1, the ultrasonic tip. This is a wired loop device to engage the file, then you pull. This is separated instrument number 2. This is number 3, the XB endoshaper that goes beyond the distal apical foramen. Files number 4 and 5. In cases of limited accessibility and limited mouse opening, this is a lower wisdom, tough lower wisdom, managed on basis of hydraulics. Inject your PCC there, put your Getaperca cones, and you're done. Here also another lower wisdom with anastomosis in the mesial and distal root. Healing of large lesions. Healing of a large lesion. This is a 2-year recall, shows complete healing. 3 months recall, the X-ray on the right shows significant reduction in radiolucency size. And here is after 1 year recall, there is complete healing, and the sealer did not prevent the healing. Healing of a large lesion related to the distal root of lower first molar. Here also healing after 8 months, despite there is a separated file beyond the distal mesial root, sorry. There is healing, and the sealer did not affect the outcome. Here is a radiolucency, here is after 8 months, significant reduction in radiolucency size. This is a 4-year recall, the lateral canal is still filled with the sealer. The sealer did not wash out. This is a lower wisdom retreatment. Look at the furcal bone loss. These teeth, some colleagues extract such case scenario, but after you thoroughly disinfect, this is a lateral canal related to the furcal bone loss. After 8 months, there is complete bone formation, after 8 months only. Also, 1.5-year recall shows complete healing. Okay. Anyone here practicing vital bulb therapy? Raise your hands, please. Anyone here practicing vital bulb therapy? No one? That's unfortunate. Okay. So please pay attention to this part of the lecture. After this lecture, I assume you will reduce your root canal treatment cases to 30%, and about 70% will do vital bulb therapy. So please pay attention. American Association of Endodontists position statement on vital bulb therapy. Vital bulb therapy techniques are means of preserving the vitality and function of the dental bulb after injury resulting from number 1, trauma, number 2, caries, number 3, restorative procedure. Vital bulb therapy procedures have traditionally included indirect or direct pulp capping and partial or complete pulpotomy. You have 5 steps to do before you're doing vital bulb therapy. You have to know it. Number 1, diagnostic consideration for vital bulb therapy. You should have sound diagnosis. You should have correct diagnosis. The current A diagnostic terminology assigns a vital bulb to one of 3 categories: normal, reversible bulbites, and irreversible bulbites. Number 2, caries management. You should remove all the decay, no any caries left behind. Any residual caries left behind will affect the prognosis and will lead to failure later on. So you have to remove all the decay. Number 3, use of sodium hypochlorite. Sodium hypochlorite is an antimicrobial solution that provides hemostasis, disinfection of the dentine bulb interface. Hemostasis can be achieved within 5 to 10 minutes either via direct passive irrigation, you hold your irrigation needle and passively irrigate above your exposure site, or on a sodium hypochlorite soaked cotton pellet on the exposure. Use of contemporary materials in vital bulb therapy. Contemporary materials, which is the calcium silicate cements or the bioceramics, it has improved barrier quality than calcium hydroxide. And number 5, immediate placement of a permanent restorative material. The advantage of the immediate restoration is the prevention of the micro leakage, protection of the biomaterial layer, reduction of the post-operative sensitivity and thermal conductivity. The primary goal of vital bulb therapy procedure is the creation of optimal conditions for bulb tissue repair and preservation. This paragraph, a pre-treatment diagnosis of irreversible bulbitis is not necessarily an indication for pulpectomy, as more conservative treatment could be considered. What do they mean by that? They mean you can do bulbotomy in cases with irreversible bulbitis. And we'll see cases about this. Where would be different clinical applications in vital bulb therapy? Here are the examples. Direct bulb capping for upper second premolar, exposure site, capped with putty, immediate post restoration, immediate post X-ray, all in one single visit. Direct bulb capping for upper first molar, exposure site, capped with putty, immediate restoration, immediate post X-ray, all in one single visit. We don't delay the restoration. Here is a 2-year recall. The tooth is completely asymptomatic, responds normally to cold test with no any radiographic finding, and there is a barrier formed. This is a barrier that was formed beyond the capping material, the putty. By doing that, you having a successful vital bulb therapy case. Look here, this is a 4-year recall for direct bulb capping. As you see here, the capping material is inside the bulb horn. After 4 years, the bulb horn still intact again, which is a barrier that was formed and the tooth was completely asymptomatic. Here also, after 1 year, a barrier was formed and also the tooth was completely asymptomatic. Responds normally to cold with no any radiographic finding. Direct bulb capping for lower second premolar. Direct bulb capping for upper first molar, and here is the 3-year recall. The tooth was completely asymptomatic and a barrier was formed. Direct bulb capping is the static zone in upper lateral incisor. This is a direct bulb capping in upper lateral incisor. Direct bulb capping in upper central incisor. The X-ray on the left is the immediate post-direct bulb capping. The X-ray on the right is 1-year recall, shows narrowing in the bulb chamber, indicating barrier formation, and also the tooth was completely asymptomatic, responds normal to cold with no any radiographic finding. And this is 1-year recall clinical image. No discoloration occurred in the central. This is a trauma case for a 9-year-old girl. Came like this. After I took a radiograph, I found incomplete maturation of both roots, as you see here. That has an open apex in both centrals. So we did pulpotomy. And here is the 9 months recall. Complete maturation of the apex of both roots. And there is no discoloration occurred in both centrals. So you are free to use this material in the aesthetic zone with no fear of discoloration. Unlike most MTA brands that causes massive discoloration. Look, the discoloration that causes by the MTA, the white MTA. Direct bulb capping for lower second molar. And here is the 3-year recall showing barrier formation. This is the barrier that was formed. The red arrow pointing at the barrier. Also direct bulb capping for lower first molar. The X-ray on the left is 1.5-year recall. The X-ray on the right is 4-year recall for direct bulb capping. Okay. Here is a 50-year-old male who came complaining severe pain related to his lower second molar. Upon taking a radiograph, I found a deep carious lesion near the bulb related to the lower first molar. Now, what will be your treatment plan here, knowing that the first molar is completely asymptomatic? What you're gonna do in such case scenario? Simply, I did root canal treatment to the lower second molar as the bulb was inflamed. Look at the bulb. While I did direct bulb capping for the lower first molar as the bulb was healthy and could be kept alive. So I did direct bulb capping. But you need to take care and do a meticulous preoperative X-ray analysis to avoid exposure of the projected distal bulb horn. So you need to tilt your hand a little to address the carious site without exposing the whole area. So you may not be able to cap this whole area and you will shift to root canal treatment. So a meticulous preoperative X-ray analysis is important in such case scenario. And here is the 1 year recall. Both teeth are completely asymptomatic. Both are with no any radiographic finding. The first molar responds normal to recall. And here is a 2 year recall. Same plus a barrier was formed. Here is the barrier that was formed. Here is the red arrow pointing at the barrier that was formed. Direct bulb capping for lower first molar. Partial bulbotomy for upper first premolar. Partial bulbotomy for lower first premolar. And here is the 1 year recall. Complete bulbotomy for upper first premolar. Complete bulbotomy for upper second premolar. Partial bulbotomy for upper first molar. And here is a 6 months recall. Partial bulbotomy for upper first molar. Partial bulbotomy for upper first molar. Complete bulbotomy in upper first molar. It's a repeatable and a reproducible procedure. Even in this deep margin, look how deep was this margin here. We did partial pulpotomy also. Complete pulpotomy for upper first molar. Even in fractured cases, this is a fractured mesiolingual cusp, as you see here. After we removed, of course, exposure occurred. It was very deep margin. After we built the fractured cusp, we were able to do complete pulpotomy. Here is the body and here is the immediate post restoration. Starting from this case, the diagnosis is irreversible bulbitis, and the teeth were completely symptomatic. The patient came with symptoms of irreversible bulbitis, and look how large amount, profuse bleeding, dark red color blood. After removal of the all coronal bulb tissue, I was able to achieve hemostasis and find a firmly attached bulb to the canal wall that I can do complete bulbotomy. So I did bulbotomy, and here is the immediate post X-ray. Same scenario, came with irreversible bulbitis. We were able to achieve hemostasis and find a good attachment to the canal walls. Same scenario, came with irreversible bulbitis. Even in cases with bulb stone, after we removed the stone, we were able to achieve hemostasis and find a good attachment to the canal wall. We were able to do complete bulbotomy, and there is the immediate post X-ray. Even here, we did partial bulbotomy in case with irreversible bulbitis. Complete bulbotomy lower second molar. Complete bulbotomy in upper first premolar, and that's what I do in cases of vital bulb therapy. You take a part of the body, put it above the bulb, and just gentle tapping using an adhesive brush, bond brush. You may need 2 increments. Just gently pack and tap the material. Moisten with a sterile water or sodium hypochlorite. Then you remove the excess material to enhance the bonding. You can do removal of the material using sharp excavator, bond brushes, purs, sandblasting. Then you put any liner, any light cured liner material to protect the material while you're doing your etch and rinse step. You can remove the liner or you can leave it as you wish. complete cleaning the cavity from any excess material to enhance the bonding, and you are ready to do your composite restoration. Okay, this is another level in vital bulb therapy, root canal treatment and vital bulb therapy in the same case, in the same tooth. Can we do that? Can we do root canal treatment and vital bulb therapy in the same tooth? Let's find out. Here is a 9-year-old boy who came complaining severe pain that awakes related to his lower first molar. Upon taking a radiograph, I found a deep carious lesion near the bulb and incomplete maturation of the distal root. The apex was not fully formed yet. Upon exposure, dark red profuse bleeding came out with little amount of pus. Pus exists in this case. After accessing the tooth, dark red profuse bleeding came out. The clinical image on the right after trials to control the bleeding, to see where it comes from. This image told me that the mesial bulb is unhealthy and has to be removed, while the distal bulb is healthy and could be kept alive. So I did root canal treatment to the mesial root while I did capping to the distal bulb. Confit X-ray, and here is immediate post-obturation and capping using both ST for the root canal treatment and PT, the putty type, for the distal root. The X-ray on the left is 18 days recall. The X-ray on the right is 1 month recall after a stainless steel crown placement. The boy was completely asymptomatic. And here is the clinical research that supports the procedure. Combination of non-surgical endodontic and vital bulb therapy for management of mature permanent mandibular molar teeth with symptomatic irreversible bulbites and apical periodontitis. And here is the 14 months recall after more than 1 year. There is complete maturation of the distal root. This means that the distal bulb stayed alive and continued the growth of the root. The X-ray on the left is 1 month recall. The X-ray on the right is 14 months recall. I think the difference is crystal clear. Here is a part of the literature about vital bulb therapy. Treatment outcome following direct bulb capping using bioceramic materials in mature permanent teeth with carious exposure, a pilot retrospective study. Success of direct bulb capping using mineral oxide aggregate and calcium hydroxide in mature permanent molars with bulbs exposed during carious tissue removal. 1 year follow-up, randomized controlled trial, Journal of Endodontics 2019. Conclusion: teeth with carious bulb exposures and reversible bulbites can be treated successfully with direct bulb capping. MTA proved better than calcium hydroxide in terms of both success rate and pain intensity. Systematic review and meta-analysis, Journal of Endodontics 2015. Direct bulb capping with calcium hydroxide or mineral oxide aggregate, a meta-analysis. MTA has a higher success rate, results in less pulpal inflammatory response, more predictable hard tissue barrier formation. Pre-mixed bioceramics, our putty material, a novel pulp capping agent. Conclusion: the pre-mixed bioceramic material possesses favorable results and all the properties comparable to the currently recommended material for bulb capping MTA. The results are comparable or even superior. Bulbotomy of symptomatic permanent teeth with carious exposure using mineral oxide aggregate. Bulbotomy using MTA could be a good alternative for root canal therapy for managing symptomatic mature permanent teeth with carious exposure. Again, success of coronal bulbotomy in permanent teeth with irreversible bulbites, an evidence-based review. Coronal bulbotomy is an evidence-based, safe, and predictable treatment that can be offered to adult patients in teeth with irreversible bulbites as a substitute to root canal therapy. Vital bulb therapy in permanent teeth diagnosed with symptomatic irreversible bulbites, reports with long-term controls. Vital bulb therapy with partial or total bulbotomies using bioceramics under aseptic conditions is a viable treatment that will have long-term success in permanent teeth with irreversible bulbites when indicated correctly. Again, Australian Dental Journal, 2023, vital bulb therapy for permanent teeth with diagnosis of irreversible bulbites, biological basis and outcome from a bulb biology perspective and based on data from clinical trials, partial and full bulbotomy using calcium silicates are the successful treatment modalities for teeth with carious bulb exposure and symptoms indicative of irreversible bulbites. Look how many teeth were saved from root canal treatment. So remember, the best root canal treatment is the one you can avoid. And the best obturation material is what God's created, which is the dental bulb. Where root PT as a root canal filling material? In this case, I were able to fill the whole root canal system using root PT, the bioceramic putty. I did this case 5 years ago. 2 years after, the patient came complaining severe pain related to the tooth. After I took a radiograph, I found a radiolucency related to the distal root only. So I retreated the distal root only, where I filled the whole root canal system using root PT. 2 days after, the patient reported completely asymptomatic, and here is a clinical research that supports the procedure: selective root retreatment, a novel approach. You can do selective root retreatment. Even in trauma cases, you can fill such case with an open apex. You can do apexification or a putty plug, or you can fill the whole root canal system using the putty material. This is also a trauma case with an open apex where I filled the whole root canal system using root PT. This is another trauma case, but the tooth was massively distracted, where I did apical plug for the last 3 to 4 millimeters. Then I placed 2 fiber posts to compensate the lost tooth structure. Even after retrieval of the overextended getapercha, we were able to fill the distal root using the root PT, the bioceramic putty. It's an open apex. This case also, I did complete root canal system using the putty. As you see, it has an open apex. This is an apexification procedure. And that's what I do in apexification. No need for any expensive carrier to deliver the material. Just increment in the cavity, and you gentle tap and pack the material using bond brush, paper points, getapercha points, hand plugger, just simple tools. You are backing the material. That's it. No need for any sophisticated instruments. Here I used the paper point to bag the material, and you're done. Extremely curved and long roots upper second molar. This is a case with massive curvatures related to upper second molar. This is a master apical file, and here is the immediate post-obturation. Do you have any other way to obturate such mesiobuccal root? I think we don't have. Just inject your PC sealer, put your getapercha cones, and you're done. Here is another X-ray view. Bulb stone and multiple radiolucency management with 3, 6, 10, and 24 months recall shows healing. 1.5, 3-year recall for direct bulb capping. If you remember this case, we did direct bulb capping for the lower second premolar. Unfortunately, there were a hole in the crown leaking food led to caries, hence bulb necrosis and apical periodontitis. And here is a bulb stone in the bulb chamber, and here is clinically the bulb stone blocking the canal entrances. Here is the immediate post-root canal treatment. The X-ray on the right is 3 months recall, shows significant reduction in radiolucency size. 6 months recall shows healing. 10 months recall shows more healing, and here is the 3-year recall, shows complete healing. Calcification management. Look at this case. It's a shock. When you take a radiograph and find this appearance, you're shocked. I was able to find the mesiobuccal and the palatal canal first. Here is a confit for the palatal and the mesiobuccal. After a while, after 3 visits, actually, I was able to detect the distobuccal canal, which were in a bizarre location, in a weird location. It was on the distal marginal ridge. Look where the distobuccal orifice were. Of course, a tiny perforation occurred during search, which was repaired later using War root PT, and there is the immediate post-obturation and perforation repair using post-ST and PT. Hydraulics power. Bioceramics are a real savior and a game changer material. How? How bioceramics it changed our practice, our daily practice. Perforation repair. This is a male colleague who came complaining severe pain related to his lower second molar. After I removed the cataperca, I found a tiny perforation in the furcation area. After detection of the mesial canal, here is a confit X-ray, and here is the immediate post-obturation and perforation repair using both ST and PT. And here is a 1-year recall. This is another huge perforation that was prepared using the putty material. I did this case 5 years ago. I decided to repair this perforation using the putty, and here is the 4-year recall. The putty still exists, did not washed out, did not resorb, despite it is subjected to the oral cavity environment. The putty can be easily washed out, but the composite ditched at the distal margin, which is very weird. So the putty survived, the composite didn't. Here's a referred case from a colleague for the inability to find the mesiobuccal canal and for perforation repair. This is a file in the perforation site. This is a perforation site periphery after removal of the granulation tissue. This is after detection of the mesiobuccal canal, confit X-ray, immediate post-obturation, immediate post-repair using the putty, and here is immediate post-repair and obturation using the sealer and the putty, and here is the 1.5-year recall, shows healing after 1.5-year recall. External root resorption. These teeth were condemned to extraction, but we find another solution. This is a case with massive external root resorption related to the distal root of lower first molar. This is immediate post-repair, and this is 6 months recall, shows significant reduction in radiolucency size. Okay. This is a female colleague, female dentist, who came complaining severe pain and swelling related to her lower first molar. Upon taking a radiograph, I found a large radiolucency related to a massive external root resorption related to the distal root. We decided to give the tooth one more chance, so we removed all the cataperca, and here is a large H file in the resorptive defect. I decided to obturate the mesial root first as the distal root was oozing blood and exudate. So I blocked it with Teflon and filled the mesial root first. Then I did the same for the distal root, and here is the immediate post repair using the sealer, using only the sealer. And this is how external root resorption may look alike. This is an extracted tooth with an external root resorption for a radix root of lower first molar. This is a 4 months recall, shows significant reduction in radiolucency size, and the patient was completely asymptomatic, and the sealer is still the same, did not washed out, did not resorb by time, which is a very, very tough test for the bioceramic sealer to withstand such tough circumstances. Here is 8 months recall, shows more healing. And there is a study that was comparing different bioceramic sealers worldwide. They found that root ST was found to be the most effective for attachment of human periodontal ligament stem cell on the set surface. Day 0, 4 months recall, 8 months recall, 2 years recall, there is complete healing. Intentional replantation and the crack management. I did this case, I did direct bulb capping using calcium hydroxide in 2013. Unfortunately, in 2017, signs and symptoms of apical periodontitis started to appear. We did root canal treatment. The tooth almost completely healed in 2019. Unfortunately, in 2021, a horizontal crack pattern started to appear, indicating a crack. This is a crack line stained with the methylene blue dye. I decided to give the tooth one more chance, so I removed the getaperca and I did complete root canal filling using the putty material. Unfortunately, the tooth still have symptoms, so I extracted the tooth, cut the apical part of both roots, and this is the immediate post replantation. This is before, and this is after replantation. This is after, immediately after replantation, and this is the 3 months recall, shows significant reduction in radiolucency size. This is another case referred from a colleague for the inability to retrieve nor bypass the separated file in a dilacerated mesolingual canal. I extracted the tooth, cut the apical part of both root, and I did intentional replantation, so the tooth survived. Lateral canal scouting. During scouting of the distal root of lower first molar, a lateral canal was detected. Look here. The file entered through the lateral canal. Unfortunately, the file was separated inside the lateral canal. Here is a file that was separated inside. But after injection of the sealer, the problem was solved. The sealer goes beyond the separated file. Again, also after we scouted the lateral canal, it was easily filled with the sealer. Here also, after we scouted the lateral canal, it was easily filled with the sealer. This is our last part of the lecture, deep split management for non-microscopic clinicians. This is a case of upper second premolar with Vertuschi type 7. Vertuschi type 7 has the anatomy of 1, 2, 1, 2. So I'm going to tell you some tips and tricks to manage such anatomy. Number 1, stick to the reference point. Buccal cusp, palatal cusp. Number 2, precurve all your instruments, your hand files, your rotary files. Number 3, shape both canals together. And what I mean by shaping both canals together, when you start shaping the buccal canal, you will do the same for the palatal. For instance, if you start shaping using 2004 rotary file for the buccal, you'll do the same for the palatal, 2504 for the buccal, 2504 for the palatal, 3004 for the buccal, 3004 for the palatal, to reach your master apical file for both canals simultaneously. Because if you shaped one canal to the master apical file, then you started shaping the other canal. Every time you put the file to start shaping the unshaped canal, the file will tend to enter to the larger canal. So you will find difficulty to enter to the narrower one. And that's what I meant by shaping both canals together. Of course, for irrigation, use polymer or plastic needles for irrigation. And for activation, use sonic activation. And for the obturation technique, of course, hydraulic condensation, the bioceramic sealer, inject your sealer in each canal, precurve your master cones, and you're done. This is another Vertuschi type 7, has the same anatomy of 1, 2, 1, 2. This is the difficult part. This is the part where the file keeps entering sometimes here, sometimes there. So when you do my method, you will find it easy to shape both canals. Another Vertuschi type 7 has the same anatomy. The most difficult part is this part, where the canals rejoin again. This is another level of splitting, buccal and lingual, so you have to enlarge your access cavity to buccolingual direction. This is another level of splitting. Okay, this is another difficult level of splitting, so please pay attention to this part. I cannot see. This is only done by tactile and an X-ray. From the preoperative radiograph, it was clear that we have one main canal and two tiny splits were obvious in the preoperative radiograph. During scouting trial, one split was detected. So you put your file, take an X-ray. Put more files, take another X-ray. Here is one split and the main canal. Here are the two splits were detected. So we took another radiograph, we are in the splits. Now, how I will obturate these tiny splits? I cannot see, I cannot fully shape these tiny splits. Now, what you're gonna do? I tried to make Getaberka harder by precurving and putting on an ice cube to make it more stiff. Then sprayed with an endo ice to make it more stiff, but I failed. I couldn't introduce such cones in the splits. So I decided to depend on another strategy, on the hydraulics power, the power of the bioceramic sealer. So I chose the largest Getaperca cone that gives me the toughest tug back. This Getaperca cone here was 4506 Getaperca cone. Then I seared off the Getaperca till the level of the splits. So I blocked the main canal first. I sealed the main canal first. After that, I injected the sealer and added the rest of the cone. So the sealer started to flow through the tiny splits, and also there is a lateral canal starting to appear. After that, I added tapered auxiliaries, more Getaperca cones, and more sealer. This step is very important. You sear off the Getaperca at the surface level, and you're doing some coronal compaction, and you're done. You have heavily filled and buffed splits filled with the sealer, and the lateral canal also was filled with the sealer, and also the splits were heavily filled and buffed with the sealer. So it's a very, very viable treatment option. This is another level of splitting for the lower second premolar. During a scouting trial, 3 splits were detected. You put your files based on tactile, you take an X-ray, you find such splitting. Here is the master apical file for the splits. During shaping one of the splits, a rotary file was separated inside one. I tried to bypass. I was able to bypass, but not fully bypass the separated instrument. It's a very, very tough bypass, by the way. So I decided to do the same and depend on the hydraulics power. Here is the confit X-ray. And here is the immediate post-obturation using the root ST, the bioceramic sealer. The sealer flows beyond the separated file. So the blob rim is quite solved. And here is the immediate post-obturation for both the lower first and second premolars. Another level of splitting for the lower second premolar. This is what we call 3D obturation. Look the sealer, how it flows, how it fills the internal anatomy of the tooth. This is our last case. This is a case of lower first premolar, that was a part of a bridge with multiple splits were detected. And here is during scouting trials, 2 splits were detected, 4 splits were detected. And here is a master apical file for the splits. And here is a cone fit X-ray. And this is the immediate post-obturation using the sealer, wool root ST. And here is a quote from my mentor, Dr. Alan Nasih: if you're always worried about failure, you will never reach out for success. Thank you so much, ladies and gentlemen. I hope you enjoyed the presentation. Thank you.
Thank you, Dr.
Thank
Mina.
you. Thank you. Any questions? I'm more than welcome.